This is presentation number 10 in brain neoplasm series, prepared by Prof. Sharaf and revised by Prof. Rami Edward. It will be concerned with the posterior fossa tumors. We have main 4 posterior fossa tumor in children and 1 characteristic in adults. Medulloblastoma and cerebellar astrocytoma are constituting 2/3 of all posterior fossa neoplasm in children. Ependymoma and glioma of the brainstem compose the remaining third. Brainstem glioma is separated because it has a different location. It has an anterior location. In adults with posterior fossa tumor, this is usually hemangioblastoma, as it is the most common primary cerebellar neoplasm in adults. In medulloblastoma, we should consider the site of origin as the vermis in 85% of cases, and occurring in the age group 4 to 8. In older children, it may be more lateralized, being in the middle line, originating from the vermis. It extends into the fourth ventricle with development of hydrocephalus, and this is common. It is a highly malignant neoplasm, rapidly growing, and usually at time of diagnosis, more than 1/3 of cases show subarachnoid CSF spread into the spinal canal. Medulloblastoma is usually hyperdense in CT, non-contrast. On the reverse, astrocytoma on the non-contrast CT will appear hypodense. Cystic changes and necrosis can occur, and 20% may calcify. These are different shapes and varieties of medulloblastoma. In CT, there is hyperdense lesion, homogeneous. Here we have, this is the MRI T2. It appears as iso or hypo, while in T1 with it images, that one and that one, it is markedly homogeneously enhanced, and it shows restriction in diffusion with it image, ADC. And here the T1 with it images shows the homogeneous enhancement of the tumor bulging into the fourth ventricle with associated hydrocephalus, and seen originating in the middle line, associated with this and that focal seedling. So seedling can occur anywhere in the spinal cord. It's called spinal leptomeningeal seedling. Now here it is, T1 with hypo, well circumscribed, intensely enhancing mass at the posterior fossa, involving the region of the vermis, and extends slightly to the left cerebellar hemisphere. Here there is some extension, which shows cystic changes and necrotic changes as well. This is medulloblastoma, and as you said, 1/3 of cases at time of diagnosis will show leptomeningeal seedling. Now, ependymoma is arising from the cells that line ventricular system and central canal, and tumor is mostly seen as an intraventricular or spinal cord mass. In children, 70% in the posterior fossa, 70% in the fourth ventricle, 70% will calcify. So ependymoma is the tumor of 70s. 70% posterior fossa, 70% fourth ventricle, 70% calcified, and being within the fourth ventricle, it extends through the foramina of Luska and Magendie into the cerebellopontine angle, and this is characteristic. Choroid papilloma cannot do this. CT and MRI is iso or heterogeneous enhancement due to calcification, cystic changes, and blood. So this is a tumor, CT, non-contrast with calcification, MRI T2, iso intense, with contrast T1, heterogeneous enhancement, and it is seen extending into the foramen of Luska along the lateral aspect. And here and there. So extension through the exit foramina is characteristic of ependymoma. Here is another ependymoma, a lobulated mass extending inferiorly through the foramen of magnum. This is a mass, it is extending into the foramen magnum and right foramen of Luska. The tumor is centered within the fourth ventricle, inside the fourth ventricle, so you can see the obliterated lumen around, and only a small portion is seen here and there. Of course, it presented calcification and heterogeneous enhancement, and definitely intraventricular, so it is an ependymoma. Astrocytoma has the rule of 66 or two-thirds in the cerebellum, 2/3 are cysts, and 1/3 is solid. 2/3 are cysts with a nodule in children. So if you have a cyst with a nodule, with an intensely enhancing nodule in in children, big age about 9 years, this is characteristic of astrocytoma. Of course, hydrocephalus will be there, and this to be differentiated from hemangioblastoma, which is a peak 35 years. 1/3 of these tumors is solid. Calcifications are minimal. So here we have a large cyst in the midline in a child. Most common pediatric CNS tumor, most common tumor seen in neurofibromatosis. 60% is the cerebellum, 60% is cystic, and showing intensely enhancing nodule, solid component, enhancing mural nodule. This is characteristic of an astrocytoma. So again, if we repeat, most common pediatric tumor, most common tumor seen in neurofibromatosis, 60% in the cerebellum. Here it is lateralized. 66% is a cyst with large enhancing mural nodule. This is astrocytoma. In tuberous sclerosis, we have subependymal astrocytomas appearing as small tubers along the subependyme lining, like this one, like these two, and here as nodular projections into the lateral ventricles. These are characteristic of tuberous sclerosis, subependymal joint cell astrocytoma. This is contrast enhanced T1. This is flare and this is T2. In flare, of course, being a tumor, there is edema. In T2, usually they are iso intense or intermediate, and in T1 they are intensely enhancing. Generally, astrocytoma is most common pediatric CNS tumor, most common in neurofibromatosis, and third of cases are solid with or without necrotic center and calcification, and it is a part of the disease of tuberous sclerosis. Solid in tuberous sclerosis. Neurofibromatosis with facial plexiform neurofibroma, this one, that one, fibroma, subcutaneous, and a small solid cerebellar right paramidline nodule, which is seen enhancing and showing necrotic center, and may calcify in 20% of case. This is small astrocytoma of the cerebellum. 1/3 are presenting as solid masses in neurofibromatosis and tuberous sclerosis usually. The rest are appearing as cysts with mural nodule, which are enhancing intensely. This is what they call it, pilocytic astrocytoma of the cerebellum, but here it's not in the midline. It is rather in the left hemisphere. Still, we are in the cerebellum. It presents with hydrocephalus compression, large enhancing mural nodule, and large cystic component. 1/3 of tumors may present as solid only without cystic changes. This is juvenile or pilocytic astrocytoma of the cerebellum. It may be solid, it may be filling the ventricle, no seedling, no extension in the cerebellopontine angles or foramina, and this excludes medulloblastoma and even dymoma, and it is intensely enhancing with areas of necrosis in the middle. There may be calcifications. Cervicomedullary astrocytoma is another site lower down than the cerebellum in the midline. It extends, it appears as hyperintensity 2 mass, and mild enhancement is noted with multiple small cysts. It is a solid tumor. Now coming to the capillary hemangioblastomas, which are, as we know, that it's occurring usually in adults with age 35, and most common cerebellar neoplasm in adults, up to 20% as part of the von Hippel-Lindau syndrome, and are multiple. They occur mostly in the cerebral hemispheres, lateralized, more lateralized, appearing as well-defined cystic changes with mural nodule, similar to astrocytoma with different age. Here it is, mural nodule, classic appearance in contrast enhanced T1 weighted image, this one. A cyst-like posterior fossa mass with intensely enhancing mural nodule representing the tumor. And here we can see these flow-void linear shadows, tumor vessels within or going to the nidus, and it may be multiple in von Hippel-Lindau disease. The differential diagnosis is pilocytic astrocytoma in the young age and isolated hemangioblastoma in adults. Tumor vessels within a nidus. This is the nidus with tumor vessels inside, and this is enhancing nidus. In contrast, CT may be multiple von Hippel-Lindau. Differential diagnosis is pilocytic astrocytoma in young, isolated hemangioblastoma in adult. The peak age for the young is 4 to 8 to 9. The isolated hemangioblastoma peak age is 35. Brainstem glioma, mainly pons, and that's the name, pontine glioma, but it may be medullary in sometimes. 15% of all pediatric CNS tumors, this group of disease, brainstem glioma, constitutes 15% of all pediatric CNS neoplasm. Any gender, peak incidence is between 3 to 10. The majority of such tumors are infiltrative astrocytomas, or what we call low-grade astrocytomas. Recurs within 2 years. 6% was gross into adjacent cisterns. The bones is abnormally enlarged. There is flat, rotated or displaced alteration of the fourth ventricle. And T2-weighted images are best to assess the true extent of the tumor, because the signal hyperintensity of the tumor in T2 may occur inside some hemorrhagic and cystic changes. So the characteristic point is the site, the bones, the infiltrative pattern, the hyperintensity of the tumor, the pressure on the fourth ventricle as flattening, rotation or displacement because of the abnormal enlargement of the bones. Hemorrhages and cystic changes may occur. Brainstem glioma, here is a large one, 60% with gross into the adjacent cisterns, abnormal enlargement of the bones, flat, rotated or displaced fourth ventricle. T2 is the best as it appears hyperintense. Hemorrhage and cysts can occur. It can be diffuse, infiltrating, or it may be rather well defined and localized. The pressure on the fourth ventricle will result in either obliteration, flattening, rotation, or displacement from anterior to posterior. Here is the mass as medullary brainstem glioma, medullary brainstem glioma with contrast, showing heterogeneous enhancement, and pontine compressing on the fourth ventricle, and this one is pontine again, causing enlargement of the bones and extension into the medulla. Diffuse pontine glioma, here it's a large mass. In T1 weighted images appears hypointense with mass effect on the fourth ventricle, almost obliterating and flattening the fourth ventricle. It is encasing the basilar artery anteriorly, T2 is large hyper-intense time mass. In T1 the enhancement is minimal. There is no enhancement. Differential diagnosis is astrocytoma, encephalitis, Adam, lymphoma. The initial presentation of such pontine lesion is cranial nerve involvement and ataxia with encroachment on the fourth ventricle and hydrocephalus. Thank you.